again. I hope you're all well. Today we are sinking our teeth into some miscellaneous medical topics in dentistry. So here's the talk outline, guys. We're going to be talking about oral manifestations of disease, anticoagulation in dentistry, infective endocarditis, prophylaxis, hot topic, systemic disorders in the mouth, drugs in dentistry, and also looking at geriatric changes that affect oral health. Alrighty, so we know that clues that suggest systemic disease may be found in the mouth and the oral cavity. And these are instances in which, if you're a dentist, you probably want to consult your physician whenever you suspect a systemic disorder is going on. When a patient is taking a specific drug like warfarin and bisphosphonates, which are known to cause complications, and or when a patient's ability to withstand general anesthesia or extensive oral surgery should indeed be evaluated. So we're kicking off, guys, talking about oral manifestations of disease. A couple of noteworthy ones here. All right, let's just get my pen in there. And so thrush, as we know, quite common in the setting of immunosuppression. Now, immunosuppression from anything, be it diabetes mellitus, which is quite common, HIV, AIDS, and other causes include leukemia, steroid use, antibiotics. In iron deficiency, we have atopic glossitis. We'll be seeing a picture of that. We have a nice smooth tongue with atrophy of the filiform papillae. Megaloblastic anemia can give you atrophy of the oral mucosa, sometimes magenta tongue and B12 deficiency. Right, and watch out for violaceous patches in KS, which is Kaposi sarcoma. Alrighty, here an example of different kinds of tongue. Alrighty, and so we see a smooth pale tongue here, a fissured tongue, oral candidiasis, and we'll see later how this compares to oral hairy leukoplakia, a black hairy tongue, a geographical tongue which has no physiological significance. Here we have a black tongue, a raw beefy tongue on the right, and gum hypertrophy together with oral candidiasis. This is more examples, guys. I want to draw attention to the high arch soft palate that we have in Marfan syndrome. When you find this, you want to look for other clinical stigmata of Marfan syndrome. So you've got an arm span which is greater than the height. You've got arachnodactyly. You've got pictus excavatum or carinatum. You've got aortic regurgitation because of dilation of the aortic root. And you've got a whole lot of skeletal signs. Don't forget your dislocation of the lens in the eye as well. Alrighty. This is an example of the high arch palate that we have in Marfan's. This is an example of atopic glossitis. So on the right is a normal tongue, but on the left we can see atopic glossitis in that there's basically no papillae. There's atrophy of your papillae, right? Let's talk a bit about anticoagulation in dentistry. So this is an algorithm taken from a publication in Excedentia. So it's good to take a full medical history, including a drug history and any history of previous problematic bleeding. And then the next port of call, or the next departure point in the algorithm, is to check your INR, your internationalized normalized ratio, international normalized ratio. If your INR is indeed less than 3, and this is a single coagulopathy, and the algorithm says, you know what, it's relatively safe to undertake dental surgery. Of course, depending on the complexity of the procedure. If it's a minor surgery or moderately invasive, it's likely safe. But if it's major surgery, likely safe up to an INR of 2.5. Anything above that, you probably want to consult with a physician or a hematologist regarding bleeding risk. But let's go back to our initial branch point. If your INR is indeed more than 3, then if it's above 3.5, definitely you want to defer surgery and contact your physician or hematologist. If it's less than 3.5 and minor or moderately invasive, yeah, you got to look at the risk versus benefit, right? If the risk of bleeding is really, really high, then you probably want to defer. If not, then you can probably go ahead. How do drugs interact with warfarin? Nice to ask. Okay, so metronidazole, which is flagyl, often interacts with warfarin because flagyl is an enzyme inhibitor. So what it's going to do is simply prolong the half-life of warfarin. That is a bleeding risk. So you want to avoid concomitant use of these two, or if you really have to use flagyl, reduce the dose of warfarin by a third to half for the next week or so. Aspirin, as we know, is non-steroidal, but it also irreversibly acetylates cyclooxygenase, so it's an antiplatelet drug, right? So this use together with warfarin also increases the likelihood of bleeding some 3 to 5 times and may cause gastritis. Drugs, however, which are safe to co-administer with warfarin include amoxicillin, clindamycin, your macrolides like azithromycin, erythromycin, and paracetamol. Caution when using non-steroidals and warfarin together. So the new kids in the block, not so new anymore, the novel oral anticoagulants, right? The likes of a direct thrombin inhibitor, dabigatran, more affectionately termed Pradaxa, came to the market in 2010. And everybody's favorite is Xarelto, which is rivaroxaban. It's a 10A inhibitor. Apixaban, which is Eliquis, a 10A inhibitor, and edoxaban, Cerveza. So these drugs are attractive alternatives to warfarin in that you don't have to monitor your INR as frequently, right? But they have their own specific indications. Now, so there's a publication from the BMC Oral Health Journal entitled Managing Patients Taking the NOACs in Dentistry, a discussion paper on clinical implications. And this is what the study had to say, that the major concerns in treatment of patients taking your direct thrombin inhibitors and factor 10A inhibitors on the risk of hemorrhage and the absence, is the risk of hemorrhage and the absence of a specific reversal agent. Because you know that if you got warfarin and you become toxic from warfarin, you can give your vitamin K, you can give your FDPs, you can give your hemosolvics, and that'll help. But not so with the NOACs. The degree of renal function, the complexity of the surgical procedure, and the patient's risk of bleeding together due to other concomitant causes are the most important factors to consider during surgical dental treatment of patients taking the NOACs. For patients requiring simple dental extraction or minor oral surgery, interruption of the NOAC is generally unnecessary. However, for more invasive surgical procedures, a greater control of bleeding as well as discontinuation of the drug for at least 24 hours should be requested. This was another publication from the European Journal of General Practice and by Desi et al. And what they had to say was that most dental interventions can be safely performed without the alteration of antiplatelet therapy or anticoagulant therapy in patients taking the direct oral anticoagulants or vitamin K antagonists. However, before high-risk bleeding procedures, missing one dose of the DOAC on the morning of the intervention may be recommended. Let's talk about infective endocarditis prophylaxis. These are the 2015 guidelines for the management of infective endocarditis from the European Society of Cardiology. So these guidelines were drawn up based on recommendations and levels of evidence. So class of recommendations, class 1, 2, A, 2B, and 3. So in class 1, there's general consensus that the given treatment of procedure or intervention is generally beneficial. Class 3 is when the evidence points that intervention is not beneficial. Class 2 is when we have some type of conflicting evidence or divergence of opinion, with 2A lending itself more to the weight of evidence being in favor of the intervention, but 2B, the weight of evidence going against the intervention in question. And then how do we determine levels of evidence? So level of evidence A is a gold standard derived from multiple randomized clinical trials or meta-analyses. This is the gold standard. This is the highest form of evidence that you can get. Level of evidence B is somewhat less robust, which is derived from a single randomized clinical trial or a large non-randomized study. And level of evidence C is just the consensus of opinion of experts or small studies, retrospective studies, and registries. So what the guidelines have to say regarding dental procedures is that antibiotic prophylaxis should only be considered for dental procedures which require manipulation of the gingival or periapical region of the teeth or perforation of oral mucosa. And that's recommendation 2A and evidence level C. And that antibiotic prophylaxis is not recommended for local anesthetic injections in non-infected tissues, treatment of superficial caries, removal of sutures, dental x-rays, placement of or adjustment of removable prosthodontic or orthodontic appliances or braces, or following the shedding of deciduous teeth or trauma to the lips and oral mucosa. Alrighty, let's look at prophylaxis for dental procedures. So obviously, if the patient has no previous allergy to a penicillin or ampicillin, you can opt for amoxicillin or ampicillin. It's given as a single dose 30 to 60 minutes preceding the procedure. In adults, the dose is 2 grams orally or IV. In kids, it's 50 milligram per kg orally or IV. However, if there is an allergy on board, you don't want to go with penicillin. You want to go with an alternative like clindamycin. The dose that we give in adults is 600 milligrams orally or IV. In kids, 20 milligram per kg orally or IV. Alternatively, you can use a cephalosporin like cefalexin or ceftriaxone or cefazolin. However, please note here, cephalosporin should not be used in patients with anaphylaxis, angioedema, or urticaria after intake of penicillin or ampicillin. There's a 10% cross-reactivity between cephalosporins and penicillins. Watch out. Non-specific prevention measures, these should ideally be applied to the general population, particularly reinforced in high-risk patients, that they should have strict dental and cutaneous hygiene, and dental follow-up of these endocarditis patients should be performed twice a year in high-risk patients and yearly in others. Okay, let's talk about systemic disease in the mouth. Okay, other cardiovascular issues. Please note, guys, that regarding adrenergic drugs like adrenaline, these are often added to local anesthetic preparations to increase the duration of anesthesia. Now, in some cardiovascular patients, excess amounts of these drugs cause arrhythmias, myocardial ischemia, or indeed hypertension. So, plain anesthetic can be used for procedures which require less than 45 minutes, but in longer procedures or where more hemostasis is required, up to 0.04 milligrams of adrenaline, which is equivalent of 2 dental cartridges of 1 in 100,000 solution of adrenaline, is considered safe. Generally, no healthy patient should receive more than 0.2 milligrams of adrenaline at any one appointment. Now, absolute contraindications to adrenaline include the following: uncontrolled hyperthyroidism, pheochromocytoma, where your systolic is above 200 moles mercury and diastolic above 115 moles mercury, right? Uncontrolled arrhythmias despite drug therapy, unstable angina, and if the patient had a myocardial infarct or a stroke within the preceding 6 months. All right, let's talk about cancer. Now, extracting a tooth adjacent to a carcinoma of the gingiva, palate, or antrum facilitates invasion of the alveolus, which is the tooth socket, by the tumor. Therefore, a tooth should be extracted only during the course of definitive treatment, be that chemotherapy or radiotherapy. In patients with leukemia or agranulocytosis, infection may follow an extraction despite the use of antibiotics. Other hematological issues in dentistry: people who have disorders that interfere with coagulation, like people with hemophilia or acute leukemia, thrombocytopenia, require medical consultation before a dental procedure that may have a high bleeding risk, like extraction or tooth cleaning or mandibular block. Now, patients with hemophilia should have clotting factors given before, during, or after an extraction, and any restorative dentistry procedure requiring local anesthesia, like filling. Okay, quick joke, guys. What did the dentist say to the tooth when he had to take a break? He said, "I'll fill you in 5 minutes." Now, most hematologists prefer that patients with hemophilia receive infiltrative local anesthetics instead of blocks for restorative dentistry. Oral surgery should be done in the hospital in consultation with the hematologist. All patients with bleeding disorders should maintain a lifelong routine of regular dental visits, which includes cleaning, filling, topical fluoride, and preventative sealants to avoid the need for extractions. What about immunosuppression? So people with impaired immunity are prone to several mucosal and periodontal infections by fungi, herpes, and other viruses, and less commonly bacteria. The infections may cause hemorrhage, delay wound healing, and even cause sepsis. Dysplastic or neoplastic oral lesions may develop after a few years of immunosuppression. Now, people with HIV/AIDS may develop Kaposi sarcoma, non-Hodgkin lymphoma, hairy leukoplakia, candidiasis, aptus ulcers, or rapidly progressive form of periodontal disease, something we affectionately term HIV-associated periodontitis. So here is the case of oral candidiasis versus oral hairy leukoplakia. So the obvious differences here is that leukoplakia occurs on the lateral surface of the tongue, not so with candidiasis. And as depicted, if you take a wooden spatula, you try and scrape off the lesion in candidiasis, it will come off with some bleeding, but leukoplakia will just not come off. And leukoplakia, obviously, we know the proposed etiology is Epstein-Barr virus, EBV, which is actually a pre-malignant lesion, right? But the etiology behind thrush is candidiasis, right? Here is Kaposi sarcoma of the oral cavity, a very vascular tumor that we can see on the upper palate. Here's a nice demonstration from MedComic and al, just demonstrating what oral hairy leukoplakia looks like. It's vertical white striations which may appear hairy, associated with HIV. The lesions are typically painless and benign and caused by Epstein-Barr virus. Right, let's talk about endocrine disorders in dentistry. So dental treatment may be complicated by some endocrine disorders. For instance, people with hyperthyroidism may develop tachycardia and excessive anxiety, as well as thyroid storm if given adrenaline. Now, insulin requirements, as you know, may be reduced on elimination of oral infection in diabetics. An insulin dose, therefore, may require dose reduction because food intake is limited and because the pain after oral surgery. So these patients tend to not eat, but if they take the same dose of insulin, that's a recipe for hypoglycemia. Now, in people with diabetes, hyperglycemia with resultant polyuria may lead to dehydration, resulting in diminished salivary flow, something we call xerostomia, which along with elevated salivary glucose levels contributes to the formation of dental caries. Now, patients receiving corticosteroids and those with adrenocortical insufficiency may require supplemental corticosteroids during major dental procedures. Patients with Cushing syndrome or those who are taking corticosteroids may have alveolar bone loss, delayed wound healing, and increased capillary fragility. In terms of neurological disorders in dentistry, patients who have seizures who require dental appliances should have non-removable appliances that cannot be swallowed or aspirated. And patients who are unable to brush or floss effectively may use 0.12% chlorhexidine rinses in the morning and at bedtime. Okay, we know obesity is an ever-increasing epidemic or pandemic that's plaguing our society today. Many patients with obesity, usually above WHO class 3, may have obstructive sleep apnea, Pewekian syndrome, with pulmonary hypertension, and when they sleep, the tongue falls back and occludes the airway, and that causes repetitive cycles of waking up and sleeping and waking up and sleeping and waking up, which is apnea, hypopnea episodes, right? So many of them use CPAP or BiPAP, right? But you can also use an intraoral device that expands the oropharynx. This treatment is not as effective as CPAP, but most patients tolerate using it. Okay, let's move on to drugs and dentistry. Certain drugs such as corticosteroids, immunosuppressants, and antineoplastics compromise healing and host defenses. When possible, dental procedures should not be done while these drugs are being given. Many drugs actually can cause a dry mouth, which is xerostomia, which is a significant health issue, especially among the older folks. Causative drugs often have anticholinergic effects and include certain antidepressants, antipsychotics, diuretics, antihypertensives, anxiolytic and sedative drugs, non-steroidals, antihistamines, and opioids. Warfarin issues we discussed earlier. Alright, phenytoin, cyclosporin, and calcium channel blockade, particularly nifedipine, contribute to gingival hyperplasia. Now, gingival hyperplasia develops in about 50% of persons taking phenytoin and around 25% of patients taking cyclosporin or a calcium channel blocker. However, hyperplasia is minimized with excellent oral hygiene and frequent cleaning. What about the bisphosphonates? Now, these are used in the context of patients who have osteoporosis. And they can result in anti-resorptive agent-induced osteonecrosis of the jaw after an extraction. So osteonecrosis occurs primarily when bisphosphonates are given parenterally, right, to treat bone cancer, and to a much lesser extent when taken orally to prevent osteoporosis. Diligent oral hygiene practices and regular dental care may help lower the risk of osteonecrosis of the jaw, but there is actually no validated technique to determine who is at risk of developing anti-resorptive agent-induced osteonecrosis. Stopping the dose may require dose reduction when food intake is limited because of pain post-oral surgery. Alright, so anyway, this is osteonecrosis of the jaw. Not a pretty sight at all. Guys, we're going to round up by talking about geriatrics and dentistry already. So resting salivary secretion really diminishes significantly solely due to aging. Right? Xerostomia or hyposalivation in the elderly is almost always a side effect of drugs, although meal-stimulated salivary flow is usually adequate. Now, the flattened cusps of worn teeth and weakness of the masticatory muscles may make chewing tiresome, hence impairing food intake. Loss of bone mass in the jaws, particularly the alveolar portion, dryness of the mouth, thinning of the oral mucosa, and impaired coordination of lip, cheek, and tongue movements may make denture retention quite challenging and difficult. And we know the taste buds become somewhat less sensitive, so the elderly may add abundant seasonings, particularly salt, and if the hypertensive, that is a no-no, which is harmful. And some may desire very hot foods for more taste, sometimes burning the often atrophic oral mucosa. And that is exactly why many of the older folks prefer just a tea and toast diet, but they're not going to get lots of nutrients to that. Noticeably, they become B12 deficient and have megaloblastic anemia and subacute combined degeneration of the spinal cord and all that company. Now, gingival recession and xerostomia contribute to the development of root caries. Despite these changes, improved dental hygiene has greatly decreased the prevalence of tooth loss, and most older folks can expect to retain their teeth, which is good news. Poor oral health contributes to poor nutritional intake, which impairs health in general. Now, dental disease, particularly periodontitis, is associated with a twofold increased risk of coronary artery disease. So watch out about that. Edentulous patients cannot have periodontitis because they don't have a periodontum, although periodontitis may have resulted in their tooth loss. Aspiration pneumonia in patients with periodontitis can involve anaerobic organisms that have a significantly high mortality rate. Severe bacteremia secondary to acute or chronic dental infection may contribute to brain abscesses, cavernous sinus thrombosis, endocarditis, prosthetic joint infections, and unexplained fever. Alright, these are my references. God bless you, and I hope this was helpful.